All right, let's go. Good afternoon, everyone. First of all, I want to sincerely congratulate Jeremy for actually making it through that presentation, because when Jeremy found out that he had to defend the untenable position that a needle is superior to magnetic navigation, he really wasn't feeling very well. So congratulations, Jeremy, for mustering up the energy and courage to make it through that presentation. I really wish I could have been there to see it. But of course, now I will need to present the other side, or however you want to call it, the correct side or the winning side. I should mention that I'm in the process of discussing financing for an unrestricted investigator-initiated research grant with Stereotaxis, and so I do hope that this funding will come through. Now, to begin, let's place these two technologies in perspective. So, magnetic navigation leverages advances in robotic, aerospatial, and electromagnetic engineering to allow catheters to be controlled with an unprecedented 1 millimeter, 1 degree of precision in three-dimensional space. In contrast, here is a prototype of the transeptal needle. This was commissioned by King Ashurnasirpal II of Mesopotamia. But to be fair, this technology was later refined and applied to humans, as captured by this Egyptian sculpture in the Musée du Louvre. Just in case you didn't catch those subtle differences in technology, again, this is magnetic navigation and the transeptal needle. So I hope you caught those minor differences. All right, on to the debate. So first of all, I'm going to assume that you are reasonable people who can be convinced by reasonable arguments around a reasonable endpoint. And what do I mean by a reasonable endpoint? Well, here we're comparing two different strategies, and evidence-based medicine would dictate that when you compare two different strategies, the strategy with the superior risk-to-benefit ratio should be favored. If you have a scenario A, for example, where strategy 1 is safer, but strategy 2 is more effective, there could be reasonable debate as to which should be preferred. And the same could be said about scenario B, where let's say strategy 2 is safer and strategy 1 is more effective, because it will depend on, how much safer one is, how less effective another is, and the weights that you attribute to the different factors. However, and this is where I need you to be reasonable, is if you have one strategy that is both safer and more effective, then by definition, it will have a superior risk-to-benefit ratio and hence should be favored. Just to bat this home, I'm going to add a bonus criterion, a third criterion, and that is also ease of use. And I will show you how strategy 2, which is magnetic navigation, is easier, safer, and more effective, and is therefore clearly the winner in this debate. So let's begin with that bonus criterion, and that is ease of use. Now, in terms of ease of access, I will resort to UCLA's own experience. So this is Jeremy's team describing access to the pulmonary venous atrium. And I will use their own words and read out their description, and you be the judge of whether you think this is easy or not. So how are they accessing the pulmonary venous atrium? The needle was advanced, but would not cross readily through the Gore-Tex conduit material. Okay, but that's to be expected, right? Because these are rigid baffles. Let's not pass judgment too early here. Let's continue. Multiple advances were made with RF energy at 45 watts and 90 watts using the cut setting. Nothing wrong there. A second needle was required when the first needle was found to have been bent. All right, so a needle breaks. It's not the end of the world. Let's continue. Using a combination of constant forward pressure and RF energy, the BRK needle was able to cross the conduit. So we're across the conduit with the needle, right? Home free, we would hope. But the dilator crossed into the atrium over the Torre wire, but the sheath would not readily cross. All right, so we've gone through two needles. We're having trouble getting the sheath across. So the sheath and dilator were exchanged for an Agilis 8.5 French sheath. So now we're on to a second sheath. Hopefully we're home free. Again, the dilator crossed, but the sheath would not track over the dilator. So We've gone through 2 needles, 2 sheaths. We're still not across. What comes next? Well, now percutaneous transluminal angioplasty balloons are taken out, and that virtual space between the extracardiac conduit and the pulmonary venous atrium is then dilated. So we got through 2 needles, 2 sheaths, angioplasty balloons. This does not seem simple to me. But again, you be the judge. And let's contrast that to ease of access using magnetic navigation. And again here, we will quote the operator of this technology, which happens to be me. Here we go, a quote. "The scroll wheel of a mouse was flicked with the right index finger." Is that all? Oh, there's more. Okay, the procedure was performed while comfortably seated in a cushioned chair. So essentially you're sitting in a comfortable chair playing with a mouse, and that's how you get into the pulmonary venous atrium. All right, let's look at an actual example. So here we're going up retrograde aortic with our magnetic guided catheter. It's making automatic circular movements. We're now in the ascending aorta. And as we get to the aortic root, what I like to do is flip that image to place that aortic valve in a clock face view to then direct the catheter right in the middle, as you'll see there. Once we're there, just flick the mouse. It gets into the systemic ventricle. We then direct the magnetic field towards the pulmonary venous atrium. And again, with a click of a mouse, we're in the pulmonary venous atrium. So no needles, no sheaths, no angioplasty balloons, no stress. So I hope that you'll agree that ease of access goes to magnetic navigation. So let's move on to our second criterion, and that is safety. Now, you're all aware of the complications associated with transeptal puncture. Even in structurally normal hearts, in a meta-analysis, 1% of patients have severe complications such as pericardial effusion, stroke, TIA, and death. And of course, this rate is not going to be any lower in patients with complex congenital heart disease, and they're also subject to other types of complications. I'm aware of at least 2 patients with Fontan baffles who had thoracic hemorrhage. And another, I think, important issue that's more particular to our patient population is the persistence of an atrial septal defect after transeptal puncture. Why? Because we're going through rigid baffles that could be calcified and hence less likely to be well endothelialized. And also, patients might have elevated right atrial pressures that contribute to keeping these shunts open. And so this concept of a persistent atrial septal defect with transeptal access is well described. This is a case of transeptal access in a Fontan patient who within days presented with oxygen desaturation from 96% to 86%. And of course, repeat transesophageal echo showed persistence of this shunt. Now, of course, with persistent atrial septal defect shunts, there's also another potential complication, and I'm sure you've all guessed it, systemic thromboembolic events. And of course, stroke and TIA is a major concern, but another type of systemic thromboembolic complication, and this has occurred in 2 of my own patients, is coronary embolism. And so this is a case of a 35-year-old man with transposition and a mustard baffle who 6 months post-ablation presented with chest pain that lasted 4 hours and had an acute ST-elevated myocardial infarction over the lateral leads, as you can see here, with some reciprocal changes in the inferior leads. He had a major rise in troponins, no atherosclerosis, and of course, he had a persistent baffle leak at the site of the transeptal puncture that I had performed prior to having access to magnetic navigation. Now, another important type of complication I think that we should become increasingly aware of as a congenital community, especially those among us who ablate in the pulmonary venous atrium, is this concept of silent cerebral embolism. So there's a growing literature in the AFib world showing that the incidence of silent cerebral embolism is really very, very high. In fact, 25 to 40% of patients post-AF ablation will have these new lesions that appear on cerebral MRI. Now, for a number of years, there was some debate as to the underlying mechanism. were these emboli due to char forming on the tip of our catheters, or little thrombi at the site of our ablation lesions, or perhaps little clots that were going through the sheaths, or microbubbles within the sheaths. The literature has become increasingly clear that the majority of these events appear to be due to microbubbles within the sheath, so gaseous emboli. The more you manipulate the sheaths, the more silent cerebral embolism you have. And there's actually a head-to-head comparison of magnetic navigation versus manual ablation, showing a dramatic reduction in the incidence of silent cerebral embolism from 32% to 5.8%. And this is actually despite magnetic navigation being performed by a transeptal approach. So a transeptal puncture is performed, but then the sheath is just left in place, because with magnetic navigation, you can pretty much guide the catheter anywhere you need to go. So you don't need to further manipulate the sheath or make any catheter exchanges. And so just this reduction in sheath manipulation and catheter exchanges results in a dramatic reduction in incidence of silent cerebral embolism. And on top of that, I'm proposing that we do these congenital cases using a retrograde aortic approach, which is associated with no sheath at all in your pulmonary venous atrium. And hence, we should reduce that incidence of silent cerebral embolism, hopefully close to zero. So when it comes to this second criterion of safety, again, it clearly goes to magnetic navigation. We have none of the complications associated with transeptal or transbaffle puncture, none of the persistent atrial septal defects with cyanosis, no thromboembolic complications, and hopefully a dramatically reduced incidence of silent cerebral embolism as well. And finally, the third criterion is greater efficacy. And you might be wondering, well, why am I talking about greater efficacy? Because after all, this debate is about which is superior in terms of reaching the pulmonary venous atrium. But I would contend that if you can't reach your pulmonary venous atrium, that's going to have a major impact on your efficacy. And my practice is filled with referrals of cases where the operators either believed that it was too high risk to perform a transbaffle puncture, or the transbaffle puncture failed. And so on the left here, you see an example of a patient with a Kawashima type Fontan, so no inferior vena cava. I guess theoretically, you can put a transeptal needle through a left jugular vein and puncture through a left-sided Glenn shunt, and then through the roof of an atrium, and enter that pulmonary venous circulation. But even once you're there, good luck in terms of catheter manipulation in these complex atria. Here's another example, and this was a patient referred to us after failed transbaffle puncture in a Fontan patient. Unfortunately, here at the site of the transbaffle puncture, a thrombus developed, and it did embolize. The patient had multiple pulmonary emboli, and once stabilized, referred to us for magnetic navigation. And the second reason why efficacy is lower with transeptal access is failure to reach the arrhythmia in the pulmonary venous atrium. So here you get to the pulmonary venous atrium, but you just can't get to your arrhythmia substrate. And again, we have lots of referrals for these types of patients. So this is an example of a patient with an intracardiac lateral tunnel Fontan. The electrophysiologist believed that space between the inferior vena cava and atrium was too large for a transcaval approach. And so they tried getting through that intracardiac lateral tunnel Fontan. But as you'll note, the calcification is really quite extensive, and it covers the entire anterior and septal portion. And so they did manage to perform a transbaffle puncture posteriorly, which was the area that was not calcified, but the patient had an arrhythmia that was anterior, and they just could not negotiate the catheter to get to that anterior position. So this patient is referred for magnetic navigation. It was an arrhythmia that was anterior. It propagated around the tricuspid annulus, and it was successfully ablated. This is a recently published series from the Mayo Clinic on transposition and atrial switch. And in their experience, they found that in 19% of cases, a transbaffle approach alone was insufficient to reach the critical tissue. And let me tell you, if you're starting your case series of transbaffle punctures with a minus 20% penalty because you can't reach your critical tissue, there's no doubt in my mind that magnetic navigation will provide superior efficacy. So, ladies and gentlemen, to conclude, and at the risk of offending King Ashurnasirpal II of Mesopotamia, magnetic navigation is clearly superior to needle puncture for complex ablation. Why? Because it is less complicated, it is safer, and it is more effective. Thank you for your attention.